For those people who have entered, who've just entered, there is a chat, and we ask you kindly to write your name and the country, your affiliation on the chat so that we are sure who our audience is and also where you are from. So please use the chat for that. If you have a question, please use the Q&A. We have a lot of visitors this evening. So the questions interaction is very, very welcome. And so at any time when a question comes up in your mind, put it right away in the Q&A. Then we will have time for the Q&A later on in this program. So the number is going up rapidly now. We have now 65 participants already there. So we just wait for 3 more minutes and then we will start. I see many chats now, so I'm really, really happy about that. Thank you. Keep doing that we know who our audience is and where they are from. And if you have a question, maybe already a question now based upon what you've seen of our panelists, then you can already ask the question right away in the Q&A section. I see people from Spain, from the Netherlands, from Norway coming in. That's all very nice. Very, very welcome.
Hi, René. Hi, everyone.
Hi, fine. Welcome. Yeah. Okay. So we wait 1 more minute before we start so that people still are coming in. I see many different chats coming in on. And for those of you who came in later, please use the chat to introduce yourself so that we know who you are and where you're from, what your affiliation is and what your country is. And I see one person raise her hand. So Esma, if you have a question, please put a question in the Q&A, Sandra. 2 participants raised their hands, but maybe you can ask your question in the Q&A. Okay. Welcome everybody. My name is René Keith, and I opened this webinar. In fact, for those of you who were early, it was already opened by a singer. We had a singer from Slovenia. He will be back later in the program. It's Matthias Belak, and he writes and performs his own songs, and this song was Owner of the Heart. So thank you for that, Matthias. I'm glad that we will see you back later. This is the second webinar in a series of 4 webinars that EUCOMS organizes during 2021. And my name is René Keith. I'm the chair of EUCOMS. And EUCOMS is a community of practice, an international community of practice of mental health services that want to learn from each other and do that by these webinars. And until last year, we also came together. We hope to pick up the habit of coming to a specific location again next year, but we also hope to continue these webinars because it's a very easy way to interact with people in many different countries. Today the topic will be flexible assertive community treatment. That's a community mental health model that was created and designed in the Netherlands, but then found its way to already 14 different countries on 3 different continents. And that's an interesting process because when a model goes to another country, a process of adaptation of the model takes place. And that's for us very interesting because you have different circumstances. And we bring together 2 of these countries to where the model has gone, Norway and Slovenia, to see how the process of the adaptation went and what the successes are and what the new introductions are and how the research is doing. For those of you who are for the first time in a meeting of EUCOMS, as that EUCOMS is a community of practice based upon 6 principles of community mental health. The first is human rights, support the human rights, rights of freedom, right of participation, right of work, right of health. The second is the public health approach, that we are not only a mental health service for those who are in treatment, but in fact for the whole population, for the well-being there. So we play a public health role as well. The third is the recovery principles, that our orientation is on strengths and the goals and the talents of our clients. The fourth is effectiveness. We want that we do interventions that are effective. It means there is evidence that they're effective. It supports the professionals, but also it supports the patient's values. The fifth is a network approach. So we work in a large community network, and then it really helps that the service itself operates as a network as well. And the sixth principle is that of peer expertise. That the lived experience of the people with mental health problems is a resource that we can use that enriches us. And therefore, practice what you preach. We always open our meetings. Introduction is always by peer experts. And also the outro, the closing of the meeting will be by the same peer expert. So therefore, I now give the floor to a peer expert from Norway, Justin Steffensen. Justin.
Hi, thanks, Renee. I felt a lot of anxiety coming up as all the different countries and names, and it just kept rolling on. I see 83 now. It's a little overwhelming. I'm not used to, well, I have public spoke before and I've done some stage stuff like stand-up and music, but I'm here to talk a little bit about my story a little bit, and also my story in relation to FACT and how it's been. So yeah, it's kind of hard to pick exactly where to start. Wish I did that beforehand, but I guess I came to Oslo in about 2011 and had a bit of a hard time. Went into some bad environments with alcohol and other things, and yeah, ended up in psychiatric hospitals. Usually I stayed there for several months at a time, and it took a toll on me. And somewhere around 2013 or 14, FACT was connected to me, and I got a psychologist, had a good relationship with her. There's been like hospital stays since that, but it's been nice to have someone that monitors and kind of like follows your development and knows you better than a regular like DPS. It's like district psychiatric service in Norway, because sometimes you move and then you lose a connection and stuff like that, like the connection to whatever people that are treating you. Yeah, so it's, I guess I have something like, this is most health teams at all, but I think it's important to keep the same contact person over a long period of time. I understand that there's like rotation and things get worked around, but my experience was within 2 years, I'd had 5 different contact people. And even when I asked someone directly, are you my contact person? And they said no, and later said, oh yeah, I was. That's a bit of a query, but I don't know how broad I'm sort of just saying out of what I know. So we'll probably get into a lot of different stuff later. Right now, I've been hospital free and drug free for over 3 years, and things are going well. I'm working at the user panel as an experienced consultant, and I'm also in a reference group. I've been a part of research several times, and like I said, I've done stand-up and music on stage for 280 people. So there's a lot of things that's been possible with the help of FACT and also with my own volition, I guess. So I don't know if I'm approaching the 5-minute mark, like the hard 5 of stand-up, but I think I'll carry some of my time in case I have good reflections at the end, I'm hoping. So okay. Thanks for your time. Enjoy the rest of the webinar.
Okay. Okay, well, thank you very much, Justin. Thank you for opening our meeting. And indeed, in the end, Justin will come back to share the reflections that he has on the things that we discussed in this evening. Then we go to the next speaker. And as I told in the beginning, flexible social community treatment started in the Netherlands. In fact, in the early zeros, it started there. And then it rapidly developed and became the main model of community mental health in the Netherlands. So before going to Norway and Slovenia, we thought it was a good idea to tell about the start and development at present in the Netherlands. And we found Elspeth de Ruiter ready to do that. Elspeth de Ruiter is a colleague of mine, and she's also the chair of the Association of Flexible ACT in the Netherlands. So she's really the perfect person to tell about the state of play of FACT at present in the Netherlands. Elspeth, please. Elspeth, we see the slideshow, but I don't hear you.
Yes, I have to unmute. Sorry.
Okay, very
yes.
good. Yes,
okay.
Sound and vision.
Yes. Thank you, René, for inviting me to come and talk to you all today. Before I will discuss the recent topics we were working on this year in the Netherlands, I would like to start this talk by taking a step back and discuss the origins of FACT. In the Netherlands, the treatment, next slide please, the treatment and care for people with severe mental illness was quite fragmented until the turn of this century. Okay, you can click on, sorry. Yes. People with severe mental illness were mostly treated in hospital-based settings. And as René said, around the turn of this century, two developments arose. Assertive community treatment, which came from the United States, and the second development was a growing interest in evidence-based practices and guidelines. And in a short amount of time, these two developments were integrated into flexible ACT. The Dutch FACT model combines that ACT thoroughness with shared case management. The next slide, please. FACT enables that the upscaling and downscaling of the mental health care in times of crisis, as well as the treatment and recovery for all individuals with severe mental illness can all be done by one team. And the building blocks of FACT are multidisciplinary teams, team case management, shared caseload, working with a plan board, and outreach such as home or street visits. FACT is, I think, the quickest implemented mental health model in the Netherlands. This is most likely due to concrete formulations through firstly a model fidelity scale and secondly a handbook. Furthermore, the FACT model stays dynamic. In 2014, a national evaluation was conducted about the state of treatment for people with severe mental illness. And this evaluation showed that treatment by FACT resulted in less hospitalizations, including less long-term hospitalizations and less dropouts. It also shows that patients and their relatives were highly satisfied with the provided care. At the same time, the evaluation showed that FACT focused too much on keeping control and too little on development, on real recovery-oriented work. As a result, 4 years ago, in 2017, the fidelity scale was changed. A new handbook was published based on these new findings. Next slide, please. The growing challenge for a FACT team is finding balance between sustainable chances, autonomy and opportunities, while also giving crises and social security proper attention. And finding that balance is one of the big challenges because the daily focus easily translates to pragmatic problem solving instead of working systematically on long-term development goals. And today, therefore, that balance is still a challenge and a focus of attention. Next slide, please. In the 5 minutes I have left, I would like to highlight these 5 themes, which we currently focus on in the Netherlands. These developments will find a place in the fidelity scale when the time is right. Next one, please. The first, no, next one, sorry. Next slide, yeah, no, next, yes, no. The next, please. Yes, this one. The first point is that of coercion prevention. More and more compulsory treatment is imposed onto patients in the Netherlands. Every year, the number of involuntarily treated patients is growing. As the board of FACT Netherlands, we took the initiative to draw attention to this issue nationally. We started with raising conscience about the harmful and inhumane nature of coercion. Our aim is to stop this upward trend. The next point is about working in a community. That's the previous slide. In the Netherlands, we identify 3 dimensions of recovery. Yes, this one. Clinical, societal, and personal recovery. At the different mental health organizations in our country that collaborate with FACT teams, different choices are currently made to enhance the dimensions of recovery. GGZ Noord-Holland-Noord, the organization where I currently work, chooses to strengthen the T of FACT, the treatment side. Originally, FACT teams and outpatient clinics were organized separately. Now they are integrated into 18 mental health teams. Every team works for a specific region of 40,000 inhabitants and provides all mental health care. GGZ Noord-Holland-Noord has developed a new fidelity scale. Our scale deviates on a number of points from that of the FACT fidelity scale. This approach of integrated mental health teams is specific for the region of GGZ Noord-Holland-Noord. Other parts of the Netherlands use different approaches. For instance, in light of enhancing societal recovery, social, community, or welfare teams organized by the municipalities are being integrated with FACT teams. These are on its own positive developments overall, but have consequences. Because of locally made choices, some of the teams do not comply the norms of the national FACT fidelity scale. As a result, some organizations renounce certification. Some people suspect that the end of a national FACT model might be coming closer as we work more locally or regionally. However, I think even in the new regional models, the original building blocks still function as the foundation. One of the core principles of ACT is based on firm scientific proof that integrating works better than coordinating. The fidelity scale thus moves with the diverse developments without letting go of its core principles. It's highly likely that we will adjust the fidelity scale again, just like we did in 2017. So next slide, please. Yes. And the third topic I want to discuss, this year a breakthrough initiative started in which 10 mental health organizations in the Netherlands participate. Together they form a network of mutual learning. They want to accelerate the implementation of the model of resource groups into FACT. Giving patients and their close ones the chance to take real control of their recovery process occurs only very limitedly and slowly. Too slowly for our liking. With this approach, we hope to accelerate working with resource groups and to get more insight into the factors that either promote it or hinder it. Next slide. The fourth topic concerns the promoting of clinical recovery in FACT teams. A plan is being developed in the collaboration between the Clozapine Plus working group and a department of the Dutch Society of Psychiatrists. The aim of this plan is to increase usage of clozapine for people with continuous psychotic symptoms. Clozapine is the only antipsychotic medication that has been proven to be effective for the treatment of therapy-resistant schizophrenia. And out of this group, Treatment with clozapine is successful for 40 to 60% of these patients. Recent research has shown that in the recent years, there's a small increase in the usage of clozapine, but that there is still a significant underprescription. And finally, the next slide, please. I want to mention a development regarding the enhancement of personal recovery. In the Netherlands, peer experts play a crucial role in this. At this moment, we work on a quality standard, which should be a starting point on how to integrate peer experts in Dutch mental health organizations, including fact teams. The quality standard includes relevant intervention and product of peer experts. It describes the roles and duties in different phases of the treatment process. Furthermore, it will give recommendations for the necessary culture, collaboration, and organization of peer expertise based on scientific, professional, and user evidence. We hope to meet the standard next year. So I hope that this very short presentation has provided you with an impression of a few relevant themes in FACT Netherlands. Thank you for your attention.
Well, thank you, Elsbeth, for a very clear overview of the development, in fact, of the last 2 decades, and also the themes that we are dealing with now in the Netherlands, including the resource group and use of clozapine and all those topics that you mentioned. So thank you very much for that. To Helge, do we have questions on the chat to the presentation so far?
Yes, we have a question to Justin.
To Justin, yes.
Yeah. And the question is, did you experience that you were helped to help yourself, in fact?
Leading question, Your Honor, but
yeah.
Try to keep it as short as possible, but I feel FACT helped me realize some of the resources I already had, but I feel like I developed a lot simultaneously, but I definitely had some outside perspective telling me that I am good enough as I am. So that helped me. So that's a quick one.
Okay, well, thank you very much. Were there any other questions to Helge?
Not for the time being, no.
That's the only.
Yeah.
So then to the audience, please use the Q&A for your questions in the chat just to introduce yourself or comments. But so if you have any questions or comments, please put them on the Q&A so that we can interact with you in that way. So if questions later come up on the situation in the Netherlands, Elsbeth is here, so use the opportunity, I would say. So in that case, we now go from the Netherlands to Norway, and I give the floor to Anne Landheim, who has become an expert on situation and development and research into flexible acts in Norway. Anne Landheim, please.
Thank you very much, René, and good evening to all participants on the webinar. I will, during the next 15-20 minutes, talk about the implementation and adaptation of a flexible act in Norway. So I will say something about the history, the experiences, and also some highlights from the research results which we have. So more specific, I will say something about the background for why we developed and established both ACT and FACT teams in Norway. I will say something about the status today concerning both ACT and FACT and the implementation work we have conducted in Norway, and also some highlights from research on the FACT model in Norway. A little bit about myself and why I am presenting ACT and FACT in Norway. I think that's because I have followed the adaptation and the implementation, and I have been working with the implementation of both ACT and the Flexible Act since 2009. And I have also participated in the national evaluation of both ACT and FACT. And we got the first ACT team in Norway in 2007, and the first FACT team in 2013. So it's quite a long period with ACT and FACT. And today we have more than 60 FACT teams in Norway, and we also have some ACT teams. It's 8 ACT teams at the moment. I would like to show this map as an introduction because in Norway we wanted to implement 2 service delivery models for persons with severe mental illness, which are developed in very different contexts than the Norwegian context. The ACT was developed in the United States, and the FACT model was a translation of the ACT model in Netherlands. And it may have been a long travel from the United States and Netherlands to Norway as well. We have a quite different context compared to both Netherlands and the United States. I will just give you a brief description of the Norwegian context. It's very brief, but we have 5.4 million inhabitants in Norway, and we have 356 municipalities, and most of them have a very small population density. And as you see on the map on the right-hand side, we have also, it's a long country, and we have long travel distances as well. So it's compared to the Netherlands, it's a very different context. And I think we also have perhaps one of the most developed welfare states in the world. That's good, but it's not always good because we have very many services at different levels. So a little bit about the background for the establishment and adaptation of FACT and ACT in Norway. Because we also have a fragmented and complex service system. We have a wide range of services, both in the municipalities and at the specialist level. At the state level, we have district psychiatric centers, we have hospitals or institutions for mental illness and substance use disorders. At the community level, we have primary health care, different services like home care, psychiatric centers, housing, economy, etc. And these 2 levels have 2 juridical laws, and we have also different ICT systems. And we have a challenge with diversity of services in the primary health care and the specialist health care. And often it's very little collaboration and cooperation between these services. And persons with severe mental illness, substance use disorders with a low functional level and complex problems often fall between all chairs in this fragmented service system. So there was a need for developing comprehensive and integrated services for the target group, and ACT and FACT were the answer. This is a picture. It's from a psychologist working in an outreach team in Norway. And this is a picture of one of his patients, which is in the middle. And these patients have 20 different service providers. And of course, the problem is that to know about each other, to coordinate all these services is very hard, and it's very hard to be the patients or the person in the middle who should by his own try to coordinate all these service providers. And I think this picture is a very classical picture of how persons with severe mental illness, often substance use disorders and complex problems stay, or how the system is around this person. So therefore, the health authorities in Norway said that FACT, it was one door in, and that FACT could offer almost all services from one team to the patient. So the teams, the FACT teams were expected to provide most all services, or some services may be handled by other providers, but then the FACT teams should work closely with these partners. So with FACT, we had one door into different services. So from 2009 until today, the health authorities have allocated funding to encourage the establishment of ACT and FACT. And in 2021, they allocated 230 million Norwegian crowns yearly, which is about 23 million euro, for establishment of services for persons with complex problems and who are in need of long-term services. And ACT and FACT are prioritized services. So ACT and FACT is a new way of organizing services for the target group in Norway. And I think it's both a top-down and a bottom-up movement, where the health authorities saw the need for comprehensive and integrated services in a fragmented mental health service system, and that the ACT and FACT could be the answer to these challenges. And we also see that staff, people working in the municipalities, in the mental health services, and also in the specialist services, they saw and they see persons with severe mental illness and complex problems who were suffering, and that it was really a need for ACT or FACT to make these services more integrated and coordinated. So integrated care was one of the main aims and goals of ACT and FACT in Norway. We have different white papers and the national guidelines as well, which recommend ACT and FACT in Norway. All these documents you see on the screen, they all recommend ACT and FACT. So the health authorities are very close to this movement and development of ACT and FACT in Norway. A little bit about the status and the development and the history of ACT and FACT. As I said, we got the first ACT team in Norway in 2007. And during the period from 2007 to 2014, we had 14 ACT teams in Norway. No FACT teams at all. But from 2013, we had the first FACT team. And today, we only have 8 ACT teams. We have 63 FACT teams, and we have also 6 FACT pilot projects as well. So it has been a movement from ACT to FACT. And one important reason for that is that the Norwegian context. We have regions with small population density, and we need to have a broader target group. And with the FACT model, we can have this broader target group compared to the ACT model, which is primarily for persons with psychotic disorders. So a movement to the FACT model. And we have FACT teams both in urban and rural regions. The smallest FACT team in a rural region have a population density of 5,000 inhabitants. And the team have about 15-20 patients the second year after the team started up. And they really try to follow the FACT model in such a small region. We also get FACT teams for elderly people, for persons with severe substance use disorders. And we have some forensic FACT teams, and we will have FACT teams for youth. We have some pilot projects, and the health authorities want to establish FACT teams for young people, and they have a goal to establish such teams, 30-40 teams during this year and the next year. So we still have plans for developing more FACT teams. We have some adaptations, which is adaptation to the Norwegian context. And FACT teams in Norway are organized as a binding collaboration between district psychiatric centers and the municipalities. So it's not organized in the mental health service system, but it's a collaboration and a binding collaboration. So both the district psychiatric center and the municipality or municipalities should offer resources to establish and drift the FACT team. And the goal is still to have comprehensive and integrated services. I think this way of organizing FACT teams in Norway are different from Sweden and Denmark, where the FACT teams are owned by at the state level and in the psychiatry. But in Norway, it's both owned and organized by the municipalities and the DPCs. The target group for the FACT teams in Norway, it's persons with severe mental illness, often substance use problems, with a low functional level, complex problems, and they are hard to reach by ordinary services. And they have a need for coordinated services as well. And we say that the functional level is as important as the psychiatric diagnosis. So that may also be a Norwegian adaptation. And we have different target groups in urban FACT teams and also in rural FACT teams. And in the rural FACT teams, they have a broader target group. It's persons with perhaps severe anxiety disorders or severe depression, complex problems, low functional level. But it's a more broad target group because they need to have enough patients for a FACT team. And we also see that some of the FACT teams in the big cities in Norway, which is small cities in the Netherlands, they have only the persons with a psychotic disorder. So sometimes we wonder why isn't that an ACT team instead of a FACT team. So it has been much work with the implementation process of ACT and FACT in Norway, and the Directorate of Health has financed and carried out, and 2 competence centers have carried out the implementation tools. And the one center where I work is the Norwegian National Advisory Unit on Concurrent Substance Abuse and Mental Health Disorders. And the other center is the Norwegian Center for Community Mental Health in Norway. So this is 2 centers working with the implementation of ACT and FACT. So we have translated handbooks and manuals, both ACT and FACT. we have conducted and given national training programs for staff in both ACT and FACT teams. We have made a network for team managers, regional networks for team staff, and we also do research-based evaluation, and we have auditor teams doing fidelity measurements as well. And we have made a handbook for establishment of FACT and ACT. We have also national conferences for team staff in ACT and FACT. And next year we will also have such a Scandinavian conference for staff working in an ACT or FACT team. So the last minutes I will say something about the research of the FACT model in Norway. I could use 2 days for presenting results from this research, but this will only be highlights, because we had a national evaluation of the 7 first FACT teams in Norway, which included both teams in urban and rural regions. We followed the teams for 3 years and the patients for 2 years. And this evaluation was also funded by the Directorate of Health. We used the same research design as we did when we evaluated the ACT teams in Norway as well. So we published a report in May 2020 in Norwegian, and it's not in English yet. And it was many research questions, but one of the most important was, can the FACT model be implemented in a Norwegian context, which is very different from the context in the Netherlands. We have many services, we have low population density, we have long travel distances. And we also asked whether, how useful is the FACT for the patients, and do the patients improve 2 years after intake to the teams? So very short, some highlights from this research. We found that the FACT model has been well implemented in all the 7 Norwegian teams in both rural and urban regions. We used the FACT fidelity scale from 2010, and the mean score for the total fidelity score was 4.1. So all these teams, also the rural teams, would have been certified or certificated in the Netherlands. And I think that it's a very important result that in such a different context, we still could implement the FACT model. We also found that the teams reached the intended target group, and they managed to maintain contact with the majority of the users. When following the patients in 2 years, we found that the patients had improved in a significant way with regard to housing, meaningful activities, the functional level had improved, and also quality of life. And we found a 43% reduction in involuntary hospital days 2 years after intake to the FACT teams compared to 2 years before. That is also a very important result. And we found a high satisfaction when we had interviewed patients, relatives, and team staff with the FACT team and the FACT model. We also found that the FACT team contributes to positive changes in the service system, and that the FACT team made the system less complex and less fragmented. But there was also some challenges, which is still challenges. It's the long travel distances in the rural regions. It's a challenge to offer intensive care when you have to travel 2 hours to meet a patient, and also to handle the crisis and to give good crisis solutions. It may be a problem. And also the rural teams had to delegate services to the municipalities. So it may be more fragmented. because of the low population density, we have small fact teams and we have few patients, and we may have lack of access to specialized competence in the small regions. We still have many services and gaps in the service system, and the fact teams have to coordinate, and there's a need also to clarify roles between service providers and the fact team. The fact team consists of staff from both the community or the municipality and the DPC at the state level, and they have different digital communication systems, which is a barrier for collaboration and integrated care. And it's also different communication systems between the fact team and other service providers, which also is a barrier for collaboration. And in the team, they have those who work in the municipality and those who work at the specialist level. They have different patient records and limited access to each other's patient's record, which also is a barrier for collaboration inside the team and for integrated care as well. This is the first international publication from our research. We have a research project going on. We have international participants like René and Niels Milder from Netherlands. And this publication, you have to read it. It's I think the title says a lot about what I have been speaking about now, that flexible, assertive community treatment teams can change complex and fragmented service systems. It's experiences of service providers. So go home and read this article. So to the question that fact and act, it's a long travel from the United States and the Netherlands. Did we manage to implement the models? I will say yes, the fact model has been implemented and it's useful in a Norwegian context. And I think that fact has been an innovation and a reform in the Norwegian service system for mental health. We have not reached the potential for 120 fact teams and act teams in Norway, but we are a good part of the way, I think. So thank you very much for your attention.
Okay, well, thank you, Anne. And it's really impressive how with the complex geography of Norway, how you're doing this work. It brought me last year in January all the way up to Tromsø. That was quite impressive to see your very devoted group. And I see there are many questions in the Q&A. I wanted, because of the time, to leave them now for the Q&A part later on in the program, so that we can have all the questions together, both on the situation of Norway, and then we now move to the situation in Slovenia. So, but keep asking your questions. I see many already, and I'm really happy about that. So that's the way that we can create interaction. And advantage, we don't have to go home because we already are at home. So we can read your paper even tonight after this webinar. We go to Slovenia now, and we go first with music to Slovenia. And I see Edo Belak, the father of the singer-songwriter that we have this evening. So Edo, is Matthias Belak ready to do the second song for tonight?
He's ready.
He is ready. Okay, then we have, there he is. So we have Matthias here. For those who came in later, he already did a song, but we're still waiting. Now he's going to do a second song. And later, Vesna will tell a little bit about him. Matthias, please sing your second song.
Globiny serca odceluci za čutim dotyk twoich mekich dlani. Otwieram oczy, twój dych me budzi, za moimi oczmi odswiecił dyszy. Шена ночь милая, души празднина заболи, и сон топле, полетне дни, полюб солнца, у мені збледі. Nebo je zrcalo globina tvojich očí. Nebo je zrcalo dotyk tvojich dlaní. To se mi zgodí.
Thank you, Matthias.
The deep,
The deepness is the title of the song.
The deepness.
Deepness, yes.
Okay. Well, thank you very much, Matthias. Thank you for sharing your song that you wrote yourself with us. Thank you very much. And I give the floor now to Vesna Swaap, and maybe you can also tell a little bit about your connection with Matthias and with Edo. Vesna.
Thank you very much for inviting us to your FACT meeting. It's very important for us. And I would like to say thank you to Matthias, who showed us his tenderness in this music. And I hope that everybody saw this caring hand besides him, who this is his father, Edo Belak, and he's the leader of the family movement of carers of people with mental disorders in Slovenia. He's also the beginner of the movement and the famous member of EUFAMI, the family members. So he's also becoming EUCOMS member, of course. So this is the family that we are all learning from in Slovenia. And I would like to connect this with my short presentation because we do not have as many experiences, for example, Norway and Netherlands, but we have a short history of 30 years old history that I want to share with you and to explain why did we embrace this FACT model and how are we doing it. So I'm going to my presentation. Okay. So this is me. I am a psychiatrist. I work in Slovenia for many years. So I was working a lot of time in a hospital, and then I came to this. I also worked all the time with NGOs, with errors, and I'm happy that I can represent our work that we have done together in last years. And I would like to be very clear about that the movement to community care in Slovenia, which is a small but strongly institutionalized country with a lot of hospitals and asylums, well, this movement towards community treatment and care began in the NGO with NGOs, and this is a map of only one, the largest one, NGO in the field of rehabilitation or recovery movement in Slovenia. This is NGO Shint, and it has all kinds of programs all over Slovenia. And the community mental health teams, this is Shint centers, day centers, group homes, and social and employment and vocational rehabilitation programs, and also addiction services. When the madam from the Netherlands spoke about from Norway about the need to connect services that take care about dependence, addiction problems, and with severe mental illness, we find it very important as well. And Shint and other NGOs in the field also understood from the very beginning of their development, which was 25 years ago, the thing you were speaking before, that this communication, connectedness, and integration of services is one of the main goals, and that it has to take place regionally. So with very little funds, with very little money, I was looking at these numbers before, you would laugh at it. They really established already 20 years, 25 years ago, a network of different services in Slovenia. And from this movement, which is very based on the user and carer initiative. This is a story about peer support, about people who really fight in this country for many years for rights to get treatment near their homes. This movement, which is really very much peer movement under the umbrella of NGOs, gave rise to development of community services. So I once again stress that this actually financially looking small movement really tackled the most important issues that are important not only in Slovenia but all over Europe. This is the group that actually stand it up against institutionalization, against putting people to social care homes, not only in Slovenia. This is one of our social care homes. They look very nice, but they are the place where people should not stay for long time, because this is actually end of their recovery in if having mental illness. This is a picture that says something about the money, where the money goes. So we see that the majority of funds goes to to institutional care, and that NGOs and other, it's very complicated. I shall not explain it, not to take your time, but you can see that the vast majority of funds in Slovenia goes to institutional care. So it all began with NGOs, and after that we started to develop some mental health assertive community treatment teams in hospitals. I think maybe some 15 years ago, I was working in a hospital at that time, and we developed quite a nice ACT model, even not following accurately the standards, but at least we started to follow patients after discharge. And after some time, we saw that this model doesn't follow a lot of patients, that all the Slovenia with 2 million inhabitants follows with this model from hospitals only about 300 patients. So this was nothing. And we started to develop, to work on the regional level and to develop these community mental health teams, which quickly started to acquire a flexible assertive community team model. But the basis for this development was actually the work we have done in several years, in last several years. It is the we prepared a national mental health plan in a group of professionals and NGOs and relatives and so on. So we got a strong group of committed people who developed this document, which is now accepted in Slovenia in a parliament and by the government. So it should be implemented. No? So I write here, we really were looking at the models in Europe and especially on the guidelines, European Mental Health Action Plan and so on. And we were also looking at the documents like CRPD of United Nations. And so we wanted to reform the system. We said, this is not okay. We have everybody in institutions. We have these strong hospitals, and we have to make more than just NGO move to the community, and we have to provide some medical or, let's say, primary care mental health services at the primary level. Also because we have a very high suicide rate, and you know that this community approach is quite well proved to reduce suicide rates if well organized. So we said we should redirect the funds from institutions to the local community, and we, let's say, actually managed to do it. And I just want to say that we have quite our argument in this reform was especially this suicide rate, which is very high at the east part of Slovenia. And in this part, you also have very low access to psychiatric and also other services in the area. And so this was the reason that the government let us go and accepted this document. And we have also other problems. We have very, very high workplace stress numbers, and this was also one of the reasons that a part of our plan about trying to change workplace mental health was well accepted. But the main for the reform prepared is just trying to be more local and to answer to people's needs. And we started to develop a new network of services. And this new network, which is actually developing for maybe 10 years, but really strongly with your expertise, is now 3 years maybe at the local community thing. So we are trying to prepare a network of community mental health teams with integrated flexible assertive community team models. And at this time, we already gained quite, just be careful, it's 1 year, it's 1 year and a half time. We actually managed to establish this much of community teams. The blue ones are for children and youth, and the red one are for adults. And they are starting to work, and every one of these adult teams has some kind of a flexible, assertive, mobile team with and they are trying to reach your, as I said, your expertise. So we are trying to make a local services center to persons in need, and we actually did translate this your manual, and I must admit we didn't just translate it. We added some local and our expertise from before, and we are retranslating it back to your language so that you can check with it in maybe some months. We are working on it. We have to add some things about social work, which has some specialities in this, and we have to add some things about occupational therapy, because we do not have the services organized in your way exactly. So I would like to say that these teams already have achieved some success. This is not the research as you managed to do in Norway. This was research made with little money, but it is actually an assessment about the needs of people, who were taken, who were included in these flexible teams in one of the Slovenian areas, and we really connected with other services and with the local communities well enough to answer to the needs of these people quite well. For example, about their psychological distress, which is one of the highest needs, about these daytime activities and so on. So we think that I don't know if you know this Camberwell Assessment of Need questionnaire is quite a standard for need. Show how people see what they need in different life areas, and then you ask the same questions also to professionals that are working with these people and to their carers. And if you compare this assessment, you can see there are quite a lot of differences. And if you look at the overview of this research, you can see that the most accurate assessment is from service users. So I would like to stop here if there are any questions. And I think we're in a phase of development that we have to learn from you, and we have to coordinate, and we would like to visit your services and to see how to develop further in our circumstances. And we hope that our action plans regarding development of local service will work. We have, I was speaking with Renee already, we have some problems already. So thank you very much for your attention.
Okay, well, thank you, Anne, for sharing the Slovenia story with us. And we just said in the beginning, we are still planning to do a summer school there in Slovenia and Croatia, and that will work out. And I'm impressed by all the work you've done in the circumstances there. So really happy to have you here with your story. And all well within the time frame that we set. So we now do have time for interaction, for questions. So I'd like to ask to Helge if there are questions on the chat to all the speakers that we had tonight. To Helge.
Yes, we have several questions. And the first one is from Ivana Josviak. Hi, is FACT connected with open dialogue in any way?
Is that a question to someone in particular?
No, it's an open question to
Okay.
all the FACT teams in both Slovenia, Norway, and Netherlands.
Well, maybe we can ask to all the three. Elspeth, can you say something about that in the Netherlands, about peer support open dialogue? And put on your microphone.
Every time I forgot. No, I don't know an initiative to integrate open dialogue in FACT in the Netherlands. No. There's a lot of attention to open dialogue, but no, maybe you have
Well, I
heard.
know there are examples in the Netherlands also, of course. It's not part of the model, but
No.
but the strength of the FACT model is that it's very suitable to indeed to have add-on interventions like peer support open dialogue. So although it's not in part of the model, it can serve as a model in which you can within which you can do it. And we do have examples of that within the Netherlands. Also within our own service, we're now starting it. So yeah. And I'm curious to know about the situation in Norway and Slovenia, if you work there with peer support open dialogue, and if there's some connection. Anne.
I don't think that many of the FACT teams use open dialogue as a method in Norway. I don't think so. But,
okay. Okay. And how about Slovenia? Unmute yourself, microphone.
Yes, I cannot answer this question. I think that I don't have this experience.
No. Okay.
Know about it.
Yeah, but I can bring. I don't know who asked it. I can bring the person in touch with people who deal with it in the Netherlands if there's interest to network on peer support open dialogue. Because I know people are involved in it. To Helge, are there other questions?
Yeah, and the next question is from Nina Boos and it's to Anna Landheim. Thank you for the presentation. What are facilitators for municipalities and psychiatric institutions to work together to establish FACT teams?
I will try to answer it. I'm not quite sure what the question is about, but if you ask what can be what is the good thing working together, or if you ask if they use different facilitators for doing this collaboration, I'm not quite sure. But the teams, I think before the FACT team, the municipalities and the staff there work with the patients, and at the specialist level, they also work with the same patients. And with the FACT team, they manage to collaborate and to give this patient more integrated care. I don't know if that is answer to the question.
Yeah, I hope so. And also facilitators are the funding for the government, I think, also. Yeah.
Yes, I think that is a facilitator, the funding from the government, but the funding from the government is only a small amount for establishing a FACT team.
Yeah. And we also have a question about that later on, so we can talk more about that. Yes.
Yeah, in fact, I also want to, because this topic of different forms of funding, it's recognizable, and you find it in many different countries. There's state and municipality. There are different ways of funding. How's it in Slovenia, Vesna? How about the funding in? Is it also as fragmented as what you hear?
Yes,
about
yes.
Norway?
fragmentation is a important word in Slovenia. Yes, I have looked at this Norwegian thing. We do not have so many services, but it goes this way. So this is a big problem. The integration is needed, I see. But about financing, I would like to say that these centers that I have showed you are financed completely from the Slovenian insurance agency. And we have these teams are paid from the, let's say, but the other parts of the system, like NGOs, they have to work for their money all the time. So they are on different tenders, on different contracts with the government and with other agencies, and they get money from the lottery money and so on. So this is a very difficult story for everybody else, but these new centers who actually got some, it cannot be compared with your numbers, but they got some money from the government to start working, and they have quite nice teams. With, for example, for a region it's not Norway, but it's for the region, and it's not Netherlands, but for the region about 80,000 population, we have about 30 people employed. This is quite nice for Slovenia at this time.
Okay, thank you very much. To Helga.
Yeah, we also have a specific question about the funding from Matthias Albers to Anna. If in 2021, 23 million euros are spent for 63 fact teams, that is only a bit of more than 300,000 per team. That means 4 staff at most. Is there another funding?
Yes, it is. Most of the costs for establishing a fact team is covered by the municipality and the district psychiatric center. So the funding from the health authorities is just a small amount, perhaps 1 or 2 staff. Costs for 2 staff. And it's only for a short period as well.
Yes. Thank you, Anna. And a question from Fran Silvestri. Hi, Anna. How did FACT work? How did the services work with the 20 service providers who were involved in the care of people prior to FACT? I think in regard to Roop Vestfold.
I think the FACT team has replaced many of the service providers, and they give the services from the team. But still they collaborate with some of them, like the police and also services, home services in the municipality. They need to do that, but they try to coordinate them. So it's not that much service providers anymore.
No. And a question from Nigel Henderson. How many staff are in average FACT team, and what are their professions? Thank you. And he asked all the countries.
Okay. Okay. So can you ask question again, and then we...
How many staff are in average FACT team, and what are their professions?
Yeah. Okay. Elsbeth.
Okay. It's different, but I think 10 persons a team, 1 psychiatrist, a psychologist, nurses, peer workers. That are the main disciplines. So
we have also occupational therapists, and we don't have peer workers yet.
Okay.
So but we have, yes, we have a lot of nurses, and everybody wants to have clinical psychologists. So this is quite a problem. because there are not many.
Is the problem that they are not there in Slovenia at all, or that the problem is that you can't get them to work in a vaccine test now?
No, they are here, you know, but they are quite few, so you cannot, if you want to proceed with, and everybody's institutions, you know, they don't want to leave their private practices, so there are a lot of problems, but they really want to, on the other hand, they want to lead the project, so we have a kind of a drama around there. We might need somebody to help with these negotiations, yes.
Okay, okay. Anne, can you answer the question on the staff?
Yes, we are the Norwegian fact teams, also in the rural district. It's from 7, 8, 9, 10 persons. We have psychiatrists, psychologists, nurses, social workers, and most fact teams have also peer support workers.
Yeah. Yeah, and that's all. Thank you. And also an addition from Michiel Beler, who's among us, also that there's also a peer, there's employment support according to the model of IPS, individual placement support. That's also part of the most of the fact teams in the Netherlands. Yeah.
So, yeah, and there were also some questions answered in the Q&A, but I told them Thomas Kulbrandstad asked a question to Elspeth. Do you still use the 2010 fidelity scale in the Netherlands, for example, to measure relatively newly established teams? Or do you now only use the 27 scale for all teams? And Elspeth answered, we use the 2017 scale for all teams. And I asked Elspeth, what do you hope to achieve with the RACT, Resource Group Act, in fact? And she answered, more control from the patients of their recovery process, because they are supported for a long time by a group of persons who they trust, like relatives and close friends. Do you want to add something there, Elspeth?
No, I think that's the most important part from resource groups. And
yeah,
yes, in the Netherlands,
also some.
Sorry.
Sorry.
No,
you can continue.
Go ahead.
Yeah, and also some research in the Netherlands about this, I understand, with Nils Mulder and colleagues. And Elspeth also had the answer to Anna. You told us that the functional level is more important than the diagnosis. How do you determine the functional level in Norway?
It means that you have no work, you have no meaningful activities. It's hard to manage housing. It's hard to, you have economic problems. You function very bad on many different areas in life. But you also need to have a mental disorder or mental health problems to get into the fact teams in Norway, but it doesn't mean that you need to have a severe psychiatric diagnosis.
So I saw a hand of Vesna.
Yes, I just wanted to add, thank you, Anne, I understood the question, how to measure it. You can, so there are many ways at this time, you know, one of them is this international classification of functioning that makes possible to diagnose the functional state, and the others are also other ways of, but this is one of the big questions, how to measure function. There are many questionnaires and items, but I think we should really have some common assessment model regarding this. We are using many things that are maybe not quite adequate now.
We are using something called practical and social functioning scale. I can send it to you if you want to, and we also use HONUS.
Okay, HONUS is it's very old, is it?
Yes. And also global assessment functional scale, but we don't use that in Norway anymore.
Could we connect them?
Well, it's good that you can connect on it. I would have take one final question from Colleen van Everding on whether homeless people have access to fact teams in Norway and Slovenia. Can you answer that question? And that's the last question for now because of the time. Anne and Vesna.
If the homeless people have mental problems or mental disorder or substance use disorders, are in need of many services, they may be in the target group.
Yeah. Okay. And how about Slovenia and homeless people and fact teams, Vesna?
Well, here we have everybody's insured with basic insurance, so everybody can get some health care if needed. And then we arrange this additional, of course, yes, but there are not very lots of homeless people yet in Slovenia because we have the socialist background which didn't allow homelessness.
Okay. Well, that's a good part. And okay, well, thank you very much for all your questions and all your answers. And now we, as I said, we always have the intro and the outro of a peer expert. And today that is Justin Stephenson from Oslo. So Justin, I'm gonna give the floor to you for your reflection on all the things that you heard this evening.
Yeah, thanks, Renee. And also thanks for inviting me to be a part of this. It's been pretty cool. I thought it was very nice that the Netherlands see the problematic parts of coercion. That was encouraging to hear about. I myself have been under one of those paragraphs. It's not great, but and when you saw the scale just go up, kind of like when someone shows a business scale and it's only profits, it's kind of went like that, but negatively. Yeah, I thought the panelists made themselves clear. I'm trying to think of some facts. I remember like 43% decrease in. I just remember 43%, I guess. I have some sort of reflections or like a little part of fact that is a really good thing that happened to me was that I had music therapy through FACT. So there was a music therapist there. That's why I raised my hand, because I figured it wouldn't be mentioned among the staff. But that was very helpful for me, and I could relay my emotions into songs and make melodies and play piano, and it was very nice. But then my music therapist went into like teaching music therapy to others. And then a little while I was without music therapist, but then my contact person told me about another thing, and it was even outside of the old Oslo. So I wound up in a different program and have had a lot of fun since. And that's because I think it's important for a FACT team, even though they're one smaller part of a bigger city, like here in Oslo, there are several ones, like, I don't remember all the areas of the city they are, but it's very important to sort of keep your ear to the ground and like be aware of the city's availabilities. Oh, nice, Birgit. So yeah, that's a part, and it was really nice to listen, and glad I was a part of it. Thank you. I hope everyone had a good time.
Okay, well, thank you very much for sharing your reflections with us, Justin. If there are still questions in the chat that haven't been answered, then we will ask the speakers to send you the answers, that we all put it on our website. And of course, we made a recording, so you can watch it again, and also you can share it with your colleagues who couldn't be here this evening. We're at the end of this webinar. Thank you all for attending and for your attention and being present with us. I want to ask Torbjörn, thank Torbjörn Monhagen for organizing it, Tor Helge for being the moderator, Matthias Bellack for the singing, Elsbeth de Ruiter, Anne Landheim, Vesna Swaap for your excellent presentation, and Justin for the intro and the outro. Please keep following us. I said this is a series of webinars, and the next one will be on the 8th of September on a very important topic, assertive care for people who are hard to engage. And what can we do about that? So that will be organized from Belgium, and you're very welcome to join us again. And your feedback is always welcome. Visit our website, and if you maybe think, oh, I would like to get this person, get to know this person better, use the opportunity. That's what we are a network for. I wish you a great rest of your Wednesday evening. It's springtime, enjoy it, and hope to see you again. Bye-bye for now.